My greetings and good wishes from Singapore. I believe that we all are going through tough times due to COVID-19. Hope this conference rejuvenates us. I'll be talking upon surgical management of spinal metastasis. My designation is mentioned here. The management of spinal metastasis evolution, this was published by me in 2017 in European Journal of Surgical Oncology. And what I have said here, the great divide was in 2005, where Patchell proved that surgery with radiotherapy does better than radiotherapy in treatment of metastatic spine disease. You can see that before that was era of inappropriate surgery and radiotherapy. And then after that is reestablishment of surgery and era of advanced surgery and radiotherapy. To some extent, a great improvement has happened with introduction of minimal invasive surgery. I have contributed quite a lot to evolution of minimal invasive surgery in metastatic spine disease after 2009 in this part of the world. I would think that the major revolution that has happened in management of metastatic disease is separation surgery. Separation is one of the most important minimal invasive surgical techniques, which enables us to easily introduce radiotherapy, use of stereotactic body therapy, radiotherapy, and also a good local disease control and reduce recurrence rate. We can say clearly that this picture shows that management of metastatic disease is multidisciplinary. Spine surgeon definitely forms the center of the hub. Radiation oncologist and medical oncologist definitely work very closely with us for surgical cases. Now, looking at separation surgery, we want to create a physical margin of safety of 2 to 3 millimeters between the spinal cord or the theca or the dura to give effective dose of high dose radiotherapy, which is SPRT. The pictures here clearly show that how the separation was carried out and the separation, the stereotactic body radiotherapy. This is a case of mine who had an L4 pathological fracture with thecal compression on one side. Breast CA is the primary. You can see the expansion of the posterior part of the body with the compression. The MRI shows thecal compression, nerve root compression. She underwent a 2 up, 2 down MIS procedure. Preoperatively, she was embolized. There was also a inferior vena cava umbrella put in because this lady incidentally or interestingly had a large IVC thrombus, and we had to contain it before the operative procedure. We can see that the operation was successfully carried out. Post preoperative and postoperative MRI scans do show that there is an element of good decompression and separation. See the axial cut on the of the MRI on the 8th of April 2021, showing the same. This is a picture which shows the operative steps of separation. We can see the theca on the medial side. My arrow or the finger shows the theca with the dura here. The anterior wall of the vertebral body is there. We have curated a part of the tumor, made a hole, and we are pushing the posterior part of the vertebral body with the instruments to create definitely more than 3 millimeters of space to be able to undergo a good separation surgery. Okay. Hope my talk is able to answer all these questions. Now, how do we assess if surgery is needed? Up to what are the preoperative measures taken etc., or even, which is better, SBRT or EBRT. And I will take up each and every question at the end of the talk to say that we have addressed them. The common indications for surgery are severe neurological deficit, pain from pathological fracture, or even impending spinal instability. Again, radioresistant tumors can sometimes require surgical intervention, intractable pain, or a combination of above. Mobility is very, very important in these patients. If the mobility is affected preoperatively, they become poor surgical candidates. And our aim is to restore mobility and self-care in these patients. So it is very, very important to have the ECOG score or some kind of a mobility assessment before the operation, and operation to be able to restore it back. We can also do a Frankel assessment. So in a way, majority of the patients who undergo surgery in my care are Frankel C, D, or C. We also are able to assess the spinal instability using the Syn Score. The Syn Score was developed by the Spinal Oncology Study Group. I'm a member of that. This study was led by Charles Fisher. I think most of you would be aware. This scoring system says that if the score comes out to be 13 to 18, then the spinal column is nearly unstable. It could be potentially unstable if you are between 7 to 12. This paper shows that how radiation oncologists have been able to assess this, and how the inter-observer and intra-observer error were very low by using this scoring system. And this scoring system definitely helps a lot of us to make a good decision regarding operative procedures. I think most important thing before offering surgery would be to assess the survival prognostication. We use revised Tokahashi score. The Tokahashi score is used in our system. The older one had a predictive value of 63%. The newer one has a predictive value of about 85 to 86%. Nowadays, the predictive value is going down because a lot of tumors which were supposed to be having poor prognosis, like lung, the prognosis is now improving, especially by knowing the subtypes of these tumors and their response to newer and advanced chemotherapeutic agents. And even in good prognostic patients, like the ones having breast or prostate, there are some aggressive ones who do not do very well. Hence, this system is, because of the fact that it is being generic, it is now less predictable. Similarly, the same can be said for the Tomita scoring system. I think they are there. It is important that some of our juniors follow these, because it gives them the idea of assessing the patient completely. The norms framework is quite extensive. It looks at the neurologic involvement, the oncologic status of the patient, the mechanical status of the spinal column, and the systemic features of these patients. And then you decide whether the patient requires separation surgery, stabilization, or radiation appropriately. You can see that it is quite a cumbersome framework to remember. You can see that low-grade patients with no myelopathy who are radiosensitive or radio-resistant may require either radiotherapy or surgery, and high-grade patients with myelopathy would require surgical intervention. I have published in the same paper, which I alluded to in the beginning of the talk, a easy aid memoir to see whether the patient requires surgery or not. And I go by the fact that the patient has neural deficit or not. If they have neural deficit with radiological compression, then definite surgery. Neural deficit with no radiological compression, then you have to assess for other causes of neural deficit. If you have a radiological compression, then we have to decide whether it is impending a neural deficit or not. If so, then they require surgery, or if the spine is potentially unstable, then requires surgery. If there's no radiological compression, as it happens in patients with severe pathological fracture, then you use the Syn Score to guide us for surgical procedure. I can take questions on this flow chart in the question section. Tomita's classification is important because it follows the King's method of thinking about tumors, whether it's intracompartmental, extracompartmental, or multiple involvement, and hence it helps us to influence our treatment. Tumors influence in surgical approach, definitely radioresistance of the tumor, vascularity of the tumor, and tumor size helps us to decide whether we want to do MIS or open surgery, or whether we want to go anterior or posterior. Aims of surgery, definitely if there is a cord compression, we require decompression, and if there is a pathological fracture or instability, it will require stabilization. Both these procedures can either be done by an open or an MIS technique. Open surgery would either be decompressive surgery or stabilization, which could be using a posterior pedicle screw fixation. Sometimes we may even do partial or near total corpectomy or en bloc corpectomy. I'll be able to explain it to you from these cartoons here. These are also from my paper, which is published in the Indian Spinal Surgical Journal. Here it shows on the left, it shows partial corpectomy, or the D here shows partial corpectomy, and here on the right side of your screen shows en bloc or near total corpectomy. Is contamination a concern? It is really not a concern in metastatic disease, for a reason that even because the disease is so widespread that the spillage of tumor does not really cause a recurrence, and it is an important concern in primary spine tumors. Minimal invasive surgery or minimal access surgery, which may be either kyphoplasty or vertebroplasty or stereotactic radiosurgery, minimal access surgery, or MIS percutaneous fixation. These are on the rise because they give less morbidity to the patient. Now we can see that these two pictures, the publications here talk about MIS versus open. These both are my publication. Here we show that the patients have reduced morbidity, less intraoperative blood loss, earlier introduction of radiotherapy, and lower complication rates if we use minimal access surgery. As we can see, a table from this picture from my paper shows that MIS surgery has a significant reduction in blood loss, duration of hospital stay, and time to start radiotherapy. Here, it shows that time to start radiotherapy was 3 weeks. Now we have brought it down to 2 weeks in patients undergoing MIS surgery. We can also say that even with MIS surgery, when the quantum of surgery increases, there is increase in blood loss, longer duration of hospital stay as we go down the thing. So even short or long construct with anterior corpectomy through minimal access surgery, just because of the fact that there is an increased amount of surgery, you're likely to have increased length of stay. Outcomes of percutaneous pedicle screw fixation with OPS, you can clearly show that the blood loss is less, length of stay is less, surgical complications are lower with minimal access surgery. The most important thing in minimal access surgery here, we are talking about the separation surgery or the open posterior spinal decompression surgery. Again, blood loss is lower, length of stay is lower. As I said, as I alluded to, the most important factor is the surgeon training and surgeon's expertise to be able to do it. Surgical complications in minimal access surgery to a great extent are far lower. They are in the region of 3.6% as far as the wound complications are concerned. It could be as high up to 6.7 or 20% in open patients. Again, non-surgical complications are also higher, to some extent comparable, because they are more related to the general condition of the patient and the length of surgery. This is again from one of my papers. It shows that increase in level of construct level and complexity increases the morbidity in the postoperative period. So hence, it is very, very important that you must plan simpler surgeries for these patients. Simpler and effective surgeries is the way to go forwards in metastatic spine disease. And you can see that the surgical site infection, if you go for bigger surgeries, can even be up to 1 in 3, up to 38%. Right, okay. Anterior versus posterior surgery. Posterior surgery definitely more common. More people are okay or conversant with it. Anterior surgery has more complications, more morbidity, but in certain cases, if it is required, like in isolated renal secondary or isolated breast secondary, yes, there is a place for doing a good anterior surgery. You can see that the anterior column fixation requires a cage replacement, which are load-bearing implants. Posterior column fixation requires tension bending, supporting or stabilizing implants. We can see them on the right side. Okay, the implant materials which we are using in metastatic spine tumor surgery are titanium, at present. Stainless steel or cobalt chrome are less commonly used. They are definitely used in scoliosis surgery. PeakBased implants are definitely on the rise. As you can see that the PeakBased implants have more advantage than titanium, as they do not hinder in radiotherapy planning. They do less stress shielding, and they generate less artifacts with CT or MRI. This slide shows that the titanium implants do create artifacts with CT or MRI, hinders in RT planning. The PeakBased implants, as I said, are more favorable in metastatic disease. This slide here shows the MRI on, this is a CT artifact generated by titanium screws on the left, on the right side with the PeakBased implants. We have two major publications in one in world neurosurgery and the one in radiation and oncology. Both have been annotated here. We can see that we have clearly pointed out that there is a place for these implant materials in management of these patients. More so is because that they have optimum Young's modulus, pure peak and composites like CFR peak, or have better imaging and radiotherapy compatibility. Now this shows the imaging, shows how this is an intraoperative CT done on one of my patients, showing how these implants are clear, easy to visualize the bone even during the operation. There is a place for preoperative embolization in these patients in order to reduce blood loss. It's very clear that if the embolization is done 13 to 24 hours before surgery, there is definite reduction of blood loss. These two papers are from my unit. One of them written, both of them, I'm either a senior author or an author in it. And we can see that the embolization agents, all embolization agents can be used. And if we do go for total embolization, and if it is done in 12 to 24 hours, it's the most effective. It is most effective in primary spine tumors and patients undergoing thoracolumbar corpectomy. However, if you are doing any anterior operation or even a posterior anterior partial corpectomy using a posterior approach, there is a place for embolizing these patients, even when it is breast, prostate, or lung. As I said, that the limitation of our publication was that there was some biases introduced by surgeon decision. There were retrospective studies. Still, the message is that embolization is effective in management of these patients. I'm the one who has thought and propagated this idea of use of intraoperative cell salvage in spine tumor surgery. And our study clearly shows that cell savers can be used in these patients, and the lost blood can be given back to these patients without any harm in the form of propagation of tumor or new tumor spread. And this work was also established using flow cytometric studies and cell salvage studies. Anyway, radiotherapy and surgery interval, we've published something to say that the optimal interval between radiotherapy and surgery should be about 2 weeks. Minimum interval can be 1 week. And this is also true vice versa. Patients who have undergone radiotherapy do require surgery. Optimal time should be between 1 and 2 weeks. We can say that SBRT definitely has more established method of local control, even up to 70 to 100% as against pure radiotherapy. As I can see from this slide, that SBRT provides a good local disease control and pain control. However, there are some complications that may include vertebral compression fractures up to from 11 to 39%, resulting in mechanical instability, and they may even require surgical intervention. I usually use SBRT in conjunction with MIS percutaneous pedicle screw fixation, and hence I haven't seen as many vertebral compression fractures. Post-operative imaging in these patients is commonly done by radiographs and by MRI. The MRI is a modality of diagnosing disease recurrence, infection, and complications. And as I said, that titanium implants do cause some hindrance in detecting or diagnosing one of these three conditions. However, the newer implant materials help us to circumvent these problems. Have we answered all these questions? Let us look at it one by one. How do we assess if surgery is needed? We can, as I already said, that surgery is needed in patients who have neural deficit or pathological fracture. When is the wound considered safe for RT? I've answered that the gap should be minimum 2 weeks or even up to 1 week. Does the type of tumor influence a decision? Yes. More radioresistant the tumor, the more aggressive the surgery has to be. SBRT or EBRT, definitely I favor SBRT. How to determine the most ideal surgery? There is nothing like most ideal surgery, but definitely there's a place for posterior surgery in these group of patients. If it can be done all posterior, well and good, but if you have to add an anterior column reconstruction or anterior surgery on a case-by-case basis, we can decide and do it. How do we choose the implants? There is no doubt that pedicle screw fixation form the major workhorse for treating these patients. They can be either put percutaneously or by open technique. Is there any routine postoperative imaging? The routine postoperative imaging for follow-up is plain radiographs. However, for studying recurrence and infection, we use MRI scan. What are the types of metastatic spine tumor surgery? Again, both MIS or open. Are the instrumented levels prone to tumor contamination? No, they are not. What preoperative measures can be taken? Proper assessment of the patient, proper clinical examination followed by appropriate radiological investigation and preoperative embolization. These are some things which one can keep in mind. We can clearly say that we are exploring new options and avenues for treatment of metastatic spine disease.